So the goal of our therapy in CML has been really to prevent progression to the terminal phase of accelerated phase and finally blast crisis. Okay, so you start a patient on enabled TKI, and we'll get to how you choose between them, but what kind of responses are you looking for to judge whether the patient is in, let's say, a safe zone, that they are protected from progression?
Yeah, and you know, I will say that our goals have evolved as our treatments have improved. You know, if you remember in the days of hydroxyurea and busulfan, you know, controlling the symptoms was our goal because that's the best we could do. But yeah, nowadays it's not only that, but you know, even other goals and get them off therapy and that kind of thing. But certainly preventing the transformation is important because even though these drugs also work in transformation, the efficacy is much less, not only in terms of the rate, but in the durability of the responses and all of that. So certainly once you can get them, prevent them from transforming, these patients are going to have most likely a normal life expectancy. And we have identified hallmarks at given time points that we know that when a patient gets to that level of response at that time, that is associated with a negligible probability of transformation. So these have to do with both the time and the depth of the response. And the critical time points are the early time points. We have at 3 months, at 6 months, at 12 months. For example, at 3 months, getting less than 10% transcripts is associated with excellent progression-free survival, excellent overall survival. And then at 6 months, getting to less than 1% of the transcripts, it gets to that same level. So that's what is very important, always, of course, but certainly in the first year, to make sure that your patient is progressing. And it's particularly so if you're using, for example, imatinib, where you have the option to go to a second generation. It's fine to use imatinib. In some instances, that's what you have to do, but then you have to see that your patient is progressing well into the response goals so that you minimize that risk of transformation.
So one thing that I think often confuses people is you've talked about the 3-month and the 6-month milestones that we look for. But a place where the guidelines differ is in the 12-month milestone. ELN suggests that a major molecular response with a BCR-ABL level of less than 0.1% is, and I'll use the word they do use, is optimal. But in NCCN, the guideline says, well, if you're in a complete cytogenetic remission with a ratio of about 1%, that's acceptable. How do you come to terms with these different recommendations for your own patients?
I think that the difference is mostly into what is your long-term goal. I think that I agree with the NCCN in terms of that, you know, when the patient gets to a complete cytogenetic response by 12 months, the probability of transformation and of course the survival are going to be excellent. So in that regard, the patient is fine. The NCCN has taken it further because they're focusing on, are they going to get to the deepest molecular responses and all of that. And that's fine. I think as a goal is good. But I think we shouldn't confuse the two things because number one, the value of the deeper molecular responses can be debated into what they mean for every patient. And you know, there's benefits, but there's all, you know, it doesn't prolong the survival anymore or things like that. And then number two is that sometimes developing these criteria creates a perception that if I don't have it, I have to change. And there's not always data to suggest that the change in a given scenario would be beneficial. And in some instances, you may even expose the patient to other toxicities and adverse events. So if the patient has a complete cytogenetic response by 12 months and you know their likelihood of transformation is minimal and the survival is going to be that of the general population, I don't want to change my patient to another therapy because, you know, what if I give them something that now is going to give them another side effect and they're fine. So I think that it depends on what exactly you're aiming for.
Yeah, I practice the exact same way, and I think our audience actually might be surprised to hear that from so-called experts, that we might be satisfied in some of our patients with, and often are satisfied with, a complete cytogenetic remission, especially in older patients who are just barely maybe tolerating some of these. I agree with you. You could pick another drug, but you don't know if they're going to tolerate that one or be more compliant with it.
Oh, absolutely. Yeah, I think that's important.
So what do you recommend then in terms of monitoring of patients on able TKIs? How do you do it?
Well, the way I do it, and there's variations of these in the guidelines and whatever, but the way I do it is in the first year, I do it every 3 months. You could question the 9 months because we don't have a milestone to follow, but just to make it easy for the patient to have a calendar, I do it every 3 months for the first year. If by the end of the first year my patient already has at least a complete cytogenetic response and certainly a deeper molecular response, I continue every 6 months. In the first year, I do PCRs, and I'd like to do at least 1 or 2 bone marrows, certainly at 12 months, maybe at 6 months. There's a small percentage of patients, about 10-15% of patients, who develop chromosomal abnormalities in Philadelphia negative metaphases. So I want to see that that's not the case for those patients. They may have certain implications. So usually they appear early. As the patient responds, they usually appear early. So if by 12 months, 18 months, they haven't developed that, it's not that it's not going to happen, but it's very low yield. So I continue monitoring only by PCR. We talked earlier about the patient whose PCR is negative from the beginning. Well, the best you can do then is FISH. It's more sensitive than cytogenetics, but that's why you do it at the beginning. You want to make sure that your FISH really captures that, and then you can follow your patient with FISH. Sure, you don't get information about molecular response and all of that, but that's what you can do for that patient. And again, we already talked the fact that if they have a complete cytogenetic response, the survival is going to be good. So that's, if a patient develops resistance, then I do the full assessment, and then it's important to check for mutations in addition to that. A patient who's having a good response, and even if they're lagging behind a little bit, I don't check for mutations. It has no value.
Yeah. I mean, I follow a very similar plan. The only place where we might differ maybe a little bit is if a patient has a complete cytogenetic remission by peripheral blood analysis, I don't feel as obligated to do that follow-up marrow looking for the pH negative clone, because I don't know what to do with that data actually. But I understand why we would differ on that one.
Yeah, and that's an important point. We don't really know exactly what to do with those patients. I do it because I want to know, but certainly there's no clear indication what's the strategy to address that.